something that we knew was coming as of last year, but we didn't know. It was not all the pushing that I was talking about from like stakeholders. It was less on this side of things is the time code, right? So zoom out real quick. RPM has two sides to it. Basically, it has the device readings, the supply code, give patient device, readings come back, bill for that each period, and then it has care management time spent dealing with the RPM conditions and the RPM device and sort of making sure that there's care management time for the RPM patient, right? So two separate sort of lines that it works on. CPT code for the devices, down to 2 measurements. The CPT code for that time used to be 20 minutes or more. They're adding a new code for 10 to 20 minutes. That's half of the time, half of the reimbursement of the 20-minute code. So suddenly, the barrier to get over for these to be reimbursable services has pretty much been halved as far as the time is concerned, and way more than halved, right? It's gone down to a fraction for the device side. So why do that? Right? So there's towards the end of this presentation, I'll talk a little bit about sort of pushback from particularly like the OIG, Office of Inspector General, and a few other sort of industry groups saying, you know, maybe we need to be more sort of structured and stringent on what the allowances are for these codes, right? Maybe we should go back to a device by device sort of thing where, you know, we know that you need to take a certain amount of blood pressure if they're doing blood pressure and a certain amount of weight if they're doing heart failure and yada, yada, yada. So there was pushback, and really Medicare, it pretty much ignored the pushback is the truth, and said, we support these codes. We think they're longitudinal codes, not short-term codes. And we see the value in providing care management and remote patient monitoring. So why did they say that they expanded it? So first, they're saying you should be monitoring patients sort of when it matters clinically, not to an arbitrary level. A lot of what they said in the proposed rule was like, we're putting it back to the judgment of the provider. We're not going to be prescriptive as to arbitrary lines. We're really going to say, but also once we get rid of that sort of prescriptive nature, we're also going to reaffirm the fact that like you're on the hook to show that this was a valuable thing that was reasonable within your medical decision making. So when it matters clinically, now you have this flexibility, right? An example: I'm a blood pressure patient. I go in. I am given antihypertensives. I need to be measuring once a day or once every other day for that period. Maybe that lasts 60 days, 90 days. At some point, I could probably clinically, not just because I'm lazy, clinically, realistically, not just get away with, but have the same value or near the same value taking a measurement every 3 days or twice a week or whatever it might be. This lets you do that. You're no longer having to sort of, push on the patient to take 60 measurements, or else you basically gave them a blood pressure cuff for free, right? So allows for a lighter touch program. I will say 2 measurements does seem, it's 2 measurements is a little low, right? I think the idea here is they really are pushing it back to the judgment of the provider. So it behooves everyone to make sure that you're not just billing for folks that are taking a measurement on the 1st and 2nd of the month, right? And sort of onward you march. But yeah, you want to make sure that you're pushing for the patient to have what the medically necessary, right, or reasonable amount of measurements are. So don't just shoot for 2. You want to have something in the record showing sort of really. I mean, you should. It's a good thing to have that flexibility, right? Maybe it should be 3 times a week or twice a week. Regardless, you got that flexibility added to it, which is important. The 10-minute code allows. It's similar, right? It's all these things are like allowing RPM light to some extent. So the 10-minute code for the clinical side really allows for briefer clinical interactions. 90 days out, I don't need to talk to my provider as much or the clinical staff as much about my hypertension. I've been told to avoid salt and I've been educated on the DASH diet. And really now a 10-minute interaction is reasonable. Great. Now it can be, you could have that 10-minute interaction, right? And not have a longer one when it's not needed for the patient. Zooming out again, what does this do as far as, so that's sort of current programs, right? How this can really help with current programs. It also, though, allows expansion into other modalities of RPM, where really the 60 measurement day requirement was was just making them not feasible, right? So we see this for GLP-1 tracking, tons of value in GLP-1 tracking as far as, watching the patient for the first 6 months on the right. There's side effects, and there's some who respond to it, and there's some who don't. There's some who lose weight too quickly, and you have to worry about nutritional deficiencies. But you sure don't need to take your weight every single day, and asking them to take their weight every single day might even be deleterious to the program, right? Because it's too fine an increment for them to see real difference. So once a week now is a thing you could do with it. So one side. Same thing for a lot of the respiratory conditions where spirometry was always difficult to have compliance. That was 16 measurements because one, you didn't need it, and two, it took a long time to take those measurements, and a lot of it wasn't just like standing on scale. It was like blowing into the thing and taking making sure that you did it correctly. This allows for those conditions now that really maybe you do have to take the measurement takes 15 minutes of your time or 10 minutes of your time. You don't need 16 measurements, a month. This allows for that. And then also, transitions, post-acute, where they were inpatient for a certain amount of time. Well, it used to be that you would have trouble with that 30-day cycle if they were inpatient or at rehab or inpatient sniff stuff, something like that. So it allows for that. What does the billing look like? So we'll share these slides, so I'm not going to go through sort of cell by cell. That said, the takeaway is if you look at these current codes, you're getting those two extra codes. There was some discussion as to how the sort of structure should work. The way it ended up was you have a new device supply and measurement code for 2 to 15 measurements. And then if it's over that, you would use the 16 plus like you always have. For care management time, there's now a code for 10 to 20 that you can use if it's between 10 and 20. Or if it's over 20, no change from this year or last year, you're billing the 457 and 458 the same exact way. Reimbursement has gone up in general. It's not anything specific to RPM. Although, and I'll talk about this in a second, there was talk about from the ANA to lower the RPM rate for the device codes, and that was actually sort of kiboshed by CMS. So same rates as far as same RVUs, and then the 3% or so increase in rates, right? That everything is pretty much getting. Not everything, but these types of services. So ends up looking like this. In practice, I thought it might be valuable to have a sort of illustrative example. So I pulled one of our internal customers, upstate New York, cardiology focused, but also some internal medicine, 522 patients. Because how does this let's say it's a current program in a vacuum, there's no changes. You're not, increasing the amount of patients you have. What does this look like? Because on top of expanding out to those new conditions, there's always been a certain amount of compliance loss, right, for patients. Every month, at the end of the month, a lot of my customers are staring at patients who only took 14 measurements in 30 days and saying, well, I just gave that guy a thing and he only took 14. Or they only have 18 minutes. So suddenly, without any changes, this is increasing the amount of patients that fall under billable criteria, right? Good faith, still doing it. Patients that otherwise would have slipped below the line now are above the line. What does that look like? All else equal, we have a pretty good rate of compliance. This is one of our customers that does a good job following up with patients. It's heavily into not just the measurements, diet, exercise, social determinants of health, things like that. So a lot of feedback and back and forth. Even with all that, about a 16% of patients are between 2 and 16 measurements. They're almost all like 10 to 15 or maybe 8 to 15. Maybe they go vacation and they take the device. Lots of reasons, right? But every month, about 60% of patients this year are not billable. Next year will be billable for the exact same rate as the patients that are over 16 measurements, right? So in that case, 522 patient program, that's 83 extra patients. Same analysis on the time side of the equation, right? We had patients who were between 10 and 20 minutes. For that, it's less. It's only about 6% of patients are between 10 and 20 minutes. But that adds up too. So in this slide, you can look at the first 2025. This was actually July, excuse me, not July, pardon me, June of 2025 for this group. And you can look at, with no changes whatsoever, you get about a 13% increase in revenue next year without any planned expansion or adding patients on. To be honest, a lot of patients dropped out of the program because they were taking it 5, 6, 7 times a month, and they asked for the device back because they weren't taking it enough. Things like that, right? Putting all those aside, because I think that's going to compound this. All else equal, 13% increase, which is a pretty, given that reimbursement's been going down the last few years, that's not bupkis as far as these programs go. And I think it'll be compounded up when you start adding in the other factors that this code expansion does.